On behalf of Meg Ashton, Trauma Program Manager, and Bert Blackstone, Trauma Medical Director, welcome to this presentation on DMIST, Standardizing the EMS to Hospital Continuum of Care. We will discuss the requirements, process, and implementation of DMIST at St. Mary's Medical Center. Fortunately for many of you, this is not a foreign concept. We are taking this opportunity to reintroduce this information at a time when you have more knowledge and more experience and are better able to integrate this into your practice. And to ensure that St. Mary's Medical Center is in line with the Pennsylvania Trauma Systems Foundation best practices. The PTSF requires that all trauma centers in the state utilize the DMIST vehicle to effect a predictable and replicable transfer of patient care. Transfer of patient care must include a verbal report from the EMS lead to the trauma center lead, the opportunity for the receiving individual to ask questions, and a written report from the EMS team prior to leaving the trauma center. DMIST provides standardization across EMS agencies and PA trauma centers to facilitate transfer of care. Fortunately, DMIST is applicable to all patients, medical and trauma. At this time, DMIST will only be required for patients entering the trauma center, but can be easily adapted to the emergency department in the future. The PTSF came to this decision as a result of recommendations from many national healthcare associations and requests directly from trauma centers and EMS staff to streamline the handoff process. The reporting process for the critical patient, as determined by the trauma center lead, shall be: upon arrival in the trauma bay, the patient is immediately transferred to the trauma center stretcher. Trauma personnel address critical interventions. The trauma center lead will then call an EMS timeout. The EMS lead provides the DMIST report in 30 seconds or less. Questions are asked and answered, and the process is complete. It's suggested that EMS personnel remain in the area of the trauma bay for 5 minutes or so afterwards in case any further questions pop up. This is obviously dependent on demand and agency protocols. The reporting process for the non-critical patient, as determined by the trauma center lead, shall be: upon arrival at the trauma bay, the patient remains on the EMS stretcher. The trauma center lead calls an EMS timeout. EMS then provides the DMIST report in 30 seconds or less. Questions are asked and answered, and then the patient is transferred to the hospital stretcher. At this point, the process is complete. Again, depending on agency demand and protocols, we're asking that EMS personnel remain in the area of the trauma bay for 5 minutes or so afterwards in case further questions pop up. So what is DMIST? Given that it's to be accomplished in 30 seconds or less, there is obviously a specific, replicable format for delivery. This ensures uniform and comprehensive reporting. EMS knows what they're giving, and the trauma center staff knows what they're getting. The D stands for demographics, M for mechanism of injury or medical complaint, I for injuries or illnesses, S for signs, and T for treatments. Let's look at each one of these in detail. Demographics include the age, gender, and estimated weight of the patient. If known, especially when the patient's alert, the patient's name and date of birth should be included. Everyone likes to be addressed by their name, especially in challenging times like these. M depends on the nature. While the medical patient focuses on the complaint and the OPQRST, the trauma patient should focus on the mechanism, including the time of injury, the type of injury, injury details, and, when relevant, any safety devices used. For the medical patient, I addresses relevant alerts and the sample history. But for the trauma patient, the report would include the head-to-toe survey, focusing on positive findings, not pertinent negatives. So for example, in the case of a patient with a single gunshot wound to the abdomen, I would mention the wound in the abdominal quadrant, but I wouldn't take time to report that there were no findings in the head or chest. Signs include respiratory rate, heart rate, blood pressure, OXSAT, and the Glasgow Coma Scale. EMS's evaluation of the Glasgow Coma Scale is important to injury severity scoring by the trauma center in the future. Please be sure to include it, even if it's obvious to you. And when time allows, blood sugar is a good idea. There's nothing worse than bringing in an unresponsive level 1 trauma alert that gets discharged 30 minutes later after receiving a bag of D10 because their sugar was only 20 on arrival. Ask me how I know that. T addresses treatments provided by the EMS team. Was an airway controlled? Were ventilations required? Did the patient ever receive chest compressions by EMS or anybody else, even if they weren't necessary? Are there tourniquets applied? Was supplemental oxygen delivered? IVs established? Did you pop the chest or put a tube in? What drugs did you give? How much and when? And how'd the patient like all of that? And yes, we'd like that all in 30 seconds or less, please. No pontificating. If you haven't been using this regularly up until this point, we realize there will be a learning curve, both for EMS and the trauma center staff. As we implement this process, there will be a learning curve, not only for the EMS agencies, but also for the trauma staff as well. The trauma service will be sharing the DMIST posters with EMS agencies and the trauma center staff. Educational opportunities hopefully will return to live sessions in the future, but for now, this presentation and face-to-face, or shall we say mask-to-mask discussions will also be available. DMIST will also become a part of the performance improvement process. As we integrate this into daily practice, inevitably, challenges will arise. As we all are familiar with the medical circle of life, we know it starts and ends with education. To get there, we need uniformed implementation, common practice, independent evaluation, and perpetual improvement. Together, we can make this work, and we look forward to your constructive criticism. But I will warn you, mockings and snide remarks may be ignored. One last evangelization to the singers. The Pennsylvania Bureau of EMS regulations require both a verbal and written report be conveyed before leaving the facility. The Pennsylvania Trauma Systems Foundation has determined that DMIST constitutes that information that is essential. DMIST just provides a predictable and replicable method to accomplish what we're already doing. Both the EMS Transfer of Care form and the DMIST poster are available in the appendix of the PA statewide EMS protocols. Questions, comments, and even snide remarks can be sent to the Community Trauma Safety Program at this address. St. Mary's Trauma Service would like to thank the Pennsylvania Trauma Systems Foundation, the Pennsylvania Emergency Health Services Council, and the Pennsylvania Department of Health for their assistance in delivering this information. And most of all, thank you for your continued commitment to the well-being of our community. Stay safe and stay healthy.